Hi, everyone. This is Mandy. Most of you guys know me already. I'm one of the nurse practitioners in the urology clinic at Sick Kids. Tonight, I'll be talking to you about an overview of PUV, and this will include an understanding of what PUV is, the most common treatments, medications, and procedures that your child may encounter during the course of his care at Sick Kids. The main objectives of the talk this evening will be what is PUV and why does it happen? We'll discuss important milestones from childhood to transition of care. We'll discuss PUV clinic care philosophy. And then at the end, we'll have some questions and answer time for parents and any of the kids that may be on this call. We'll start with a video that's posted on the Sick Kids YouTube page. Some male babies are born with a blockage of the urethra called posterior urethral valves, or PUV. PUV is sometimes diagnosed before birth, but sometimes after when a child develops symptoms. PUV is a chronic condition that occurs on a spectrum, and no two children with this condition are exactly the same. How rare is PUV? It's actually pretty rare, and it's only found in about 1 to 2 in 10,000 pregnancies. A PUV diagnosis means surgery to remove the blockage and very regular checkups with urology and nephrology teams until adulthood. Almost all males with PUV will experience bladder problems, such as infections and difficulty holding or passing urine. Up to 40% will require medications to help with these bladder issues, and about 30% will require catheters to help with bladder emptying. Ultimately, 10 to 15% of males with PUV will require dialysis or transplant during childhood. These kids have many trips to the hospital, lots of testing, and some will need multiple surgeries. We started the PUV clinic because at Sick Kids, we have a high volume of kids and babies with this condition. After reviewing the outcomes of PUV patients over the past many years, we knew that we should be able to improve the health outcomes and quality of care for these families by optimizing and standardizing management and moving from a reactive to a proactive approach. The PUV clinic offers consistent care to patients by a multidisciplinary team consisting of pediatricians, nurse practitioners, surgeons, nurses, and clinic support staff. The PUV clinic philosophy is proactive care and support of patients and parents. We have implemented an evidence-based clinical pathway that is continuously reassessed and modified, driven by an ongoing review of our outcomes. We share care with our nephrology colleagues and ensure families have close follow-up and dedicated clinical contacts for any concerns. We have a dedicated social worker to help support with issues as they arise and offer regular online PUV parent support groups. PUV is rare. Feedback from families tells us that they feel overwhelmed and isolated with no idea what to expect in the future or the trajectory their child may experience. In PUV clinic, we aim to improve medical outcomes in this population of children. We want to better understand the impact that this condition has on quality of life of both families and children with PUV. Finally, we want to be able to offer all forms of support for these kids and families, not just clinically, but also with a focus on social, emotional, and mental health support.
We never leave with questions, which is so beautiful. And if we do have any questions, we know that there's always somebody on call that we can communicate with. We know that the message is going to get to our doctors and we know we'll get a response. So we have security being a part of this clinic.
So what is PUV? Well, PUV is a congenital urinary tract obstruction affecting males. Congenital means that this is something that the child is born with. It happens in about 1 to 2 in 10,000 pregnancies, making it quite rare. And there's varying degrees of severity. And so depending on the severity, as you can see in the picture here, we know that this can have an impact on lung development. It can have an impact on kidney function, as well as on bladder function. And because of the spectrum of outcomes that happen in this condition. It does require close lifelong monitoring by pediatric urology and nephrology teams for ongoing management of kidney and bladder function. Why does PUV happen? The short answer here is that we actually don't really know. This usually occurs between 9 and 14 weeks of gestation when the urethra is developing. And we know that it's not related to any pregnancy behaviors or actions by the parents. This is typically a spontaneous, isolated issue, and it does not seem to have any type of genetic component. One of the most important things to remember is that the overall goal of PUV management is the preservation of kidney function. When we look at our whole population of kids with PUV, I can say that about half of them are detected prenatally or before the child is born. This usually happens at the 18 to 20 week anatomy scan, and with severe cases, this can sometimes be diagnosed a bit earlier. We are usually suspicious of PUV when we see certain ultrasound features, and those include dilation of the kidneys or ureters. This is called hydronephrosis and hydroureter. If there seems to be a large or distended bladder, and that's called megacystis. If the bladder wall looks thicker than we would expect, which is a sign of the bladder having to work hard to force urine through an obstruction. Sometimes if they're doing the ultrasound for long enough and the baby's trying to pee, we can see a dilated urethra or the urethra itself becoming dilated. And it starts to narrow at the point of the obstruction. And this is something called the keyhole sign. And then the big one is if there's low or absent amniotic fluid volume. And so when we see all or some or a combination of these findings, we tend to be more concerned that this child may be born with a lower urinary tract obstruction or posterior urethral valves. Sometimes it's helpful to see visually what we mean when we're talking about all of these terms. And so on the left-hand side of the screen is a normal urinary tract. So you see a normal kidney with good, intact, robust parenchyma. You see a normal ureter, which is the tube that joins the kidney to the bladder that's not dilated. You see a normal smooth-walled bladder, and then you see a normal thin urethra. On the right-hand side is an example of what a fetus with posterior urethral valves may look like. They have thin compressed parenchyma because of all the pressure buildup inside of the kidneys. You see that the kidneys are dilated, the ureter is dilated, and the bladder is also distended, and sometimes it's thick-walled. And this is because the level of the obstruction is in the urethra, which is the exit of the urine from the body. And as a result of that, everything upstream from that urethra is going to be impacted by this obstruction. And so in this section, I'll bring up some of the important milestones and the monitoring that happens around those times in the journey of a child who has PUV. So the first milestone or the first important time is when these babies are born and they're newborns and babies, and we acknowledge that this is probably a very stressful time for families. They've either been anticipating this moment from the time that they're pregnant or their baby is born, and this is something that we're working up after the fact because they've come with abnormal ultrasound findings or because their child has gotten sick. During this time, kids are followed very regularly with ultrasounds. If this is something that we know about when the baby's born, as soon as that happens, we decompress the bladder with a stent or a catheter. We then have to do a VCUG, which is the contrast study to confirm the diagnosis. Then comes surgery. We'll talk about more about that as we move forward through the slides and the different options that are offered for a child who has PUV. You guys know that there's frequent blood work that happens at this time. And of course, the child has a stay in the hospital. The next important time that we consider in terms of milestones is going to be around toilet training age. And that's because this may be the first time that we start to see signs of bladder dysfunction. And so as we mentioned earlier on, we know that most kids with PUV are going to have some component of bladder dysfunction as they grow and develop, and that it's difficult to understand early on kind of where each child is going to end up on that spectrum. And so during toilet training age may be the first time that we start to see signs of this. And evidence of bladder dysfunction could be challenges with toilet training. So kids are having a lot of pee accidents, or now they start to develop infections, or they're having a tendency to hold their pee for too long. Sometimes toddlers can have a tendency to get constipated during toilet training age.
And we know that constipation directly impacts bladder function. At this time, we may start to see changes on the ultrasound. So kidneys and ureters that were completely decompressed before are now starting to look like they're having more hydronephrosis or hydroureter, and that's because of bladder dynamics. And this may be a time that we could start to see the creatinine increasing as well. And so the next important milestone time is when they become school age. And the reason for that is because this is the time that they start to gain independence with respect to bathroom habits. Some kids have a tendency to go to school all day and they don't go to the bathroom because they're not being reminded like they are at home. They start holding their pee for long periods of time. It's another time period where we might start to see signs of bladder dysfunction because of this. And then this is a challenging time because it makes us question, is this issue that we're seeing, so for example, pee accidents or your pee holding, is this a PUV bladder issue related to the underlying bladder dynamics associated with this condition? Or is this a regular school age problem like bladder and bowel dysfunction that we see in many, many kids in our urology clinic who don't have anything underlying? And so it is easy to have a tendency to write off these types of issues as behavioral and bladder bowel dysfunction and miss that this could be a sign that there's something going on with the bladder related to the valves. Again, this is a time that we could start to see changes in the ultrasound as a result of these bladder dynamics. And the reassuring thing is that once they get to this age and toilet training is established, these kids are old enough to do flow studies in our clinic, and that gives us a urinary curve and a measurement of their post-fluid residuals. And what that means is that we can see how effectively they're able to pee, and if they're able to generate a good normal pee curve without any pushing or straining to pee or a weaker dribbling stream. And so this test is something that's repeated at every clinic visit and gives us lots of helpful information about the child's urinary tract in a non-invasive way. And so the final milestone that we have to consider while these children are still in pediatric care is when they become adolescents and teenagers. And just like every other teenager that people may have to deal with in their families, this is a time when they're really starting to gain independence. And it is a time that we start to see an issue with adherence to the treatment plans. So kids who need to take medications or kids who need to do catheters, this is a time when they may slip in those habits, and that can result in some deterioration of how they're doing. Another issue that happens during adolescence and puberty is that in boys, this is a time when they start to develop muscle mass. Muscle mass means that there's going to be more creatinine that needs to be cleared from the bloodstream. And as you know, creatinine is the measure of kidney function. And so with all of this muscle developing happening and this increase in creatinine, it makes a higher demand on the kidneys. And so at this point, we may see a rise in the creatinine, and we have to question ourselves and wonder, is this related to normal pubertal changes that we see in other kids who are going through puberty and becoming teenagers? Or is this a sign that there could be a compromise in kidney function related to progression of the posterior urethral valves and the outcomes that go along with that sometimes?
And so, of course, the last important milestone is when children turn 18 and then they graduate from SickKids. And a lot of people have asked us what happens to these kids when they grow up and they have to move to the adult world. And I have to say that we've looked into this, and as of now, not a lot is known about this topic of what happens to PUV patients when they graduate. So because there's not a lot of information out there about adult PUV patients, we decided to look into this ourselves. And so we did a population health study using an administrative database here in Ontario, containing health information for all of the residents. We gathered all the PUV patients, and we found that from 1991 to 2021, there were 727 of them, which means that from our data, PUV is actually happening in about 1 to 3 in 6,000 live births. The age at diagnosis when this is found is around 40 days, so most of them are not being detected prenatally. We compared them to kids with another type of urinary tract obstruction requiring a different surgery called pyeloplasty. And for those, we had 855 of them.
And we then compared them to kids without any urological history, so healthy kids in the general population, and there were over 1 million of those for the same time period. And so the purpose of this slide is not to be alarming or to scare you guys. The purpose of this slide is to demonstrate how PUV patients are different from the other two populations that I just mentioned, and to highlight the importance of proactive care that happens at regular intervals from early on until you guys graduate from the hospital, because these data show that PUV patients do experience significantly more major adverse kidney events or poor kidney outcomes compared to kids with other types of urinary tract issues, as well as the general population. And not surprisingly, we see that kids who have PUV, they have a higher rate of chronic kidney disease, they have a higher rate of developing hypertension as they get older, and they have a higher rate of needing a kidney transplant or dialysis compared to pyeloplasty patients or patients who belong to the general healthy population. This chart is from that study, and what it is showing us is that this solid line that you see kind of creeping up early in childhood, so years to follow-up is at the bottom, this line that seems to be creeping up fairly quickly early on and then tends to kind of level out, is the major adverse kidney events or the poor kidney outcomes. And these represent the PUV patients. So you can see that initially there's a steep increase, it kind of steadies out, but then it does continue into young adulthood. The red line that you see is 18, which is when they graduate from sick kids. And this figure is stressing the importance of regular continued follow-up by specialists once the child moves from sick kids and into the adult world, because we know that they don't suddenly all get better at that point. We know that there is a potential for further decline in kidney function, and this is something that they need to have monitored regularly, even as they get older. The dotted line at the bottom as a comparison is how they compare to those 1 million healthy children without a urological history. While there weren't many studies that I could find, there was this study published in 2011 that looked at bladder function in adult men with a history of posterior urethral valves. And what they found was that the urinary problems that kids experience, they certainly don't go away. And there are common urinary issues that happen in these adults, such as incontinence, weak urinary stream, urinary frequency, urinary urgency, a feeling of having to strain or push hard to pee, a problem with having dribbling after they go peeing. So they pee, they think that they're finished, but then they have some dribbling that happens after, and that's because of incomplete emptying. And so these are common things that may still happen into adulthood, and most of these are very manageable with interventions or medications. Another common question that comes up sometimes with parents is that they're wondering if there's any concern when it comes to reproduction for their children when they become adults. There is one study that we found from 2012 that shows that, reassuringly, the paternity rates of men with a history of PUV is similar to the general population. They have similar erectile function as the general population, and there's no difference in ejaculatory function, which seems to reflect the fact that having a history of posterior urethral valves will not have any impact on fertility or reproduction as compared to the general population. Another common thing that we're asked about is how this impacts quality of life as these children grow up. This paper is from 2013. And again, it seems as though when there's a self-report of men with a history of PUV, that the quality of life seems to be similar to the general population. And when they notice that there is an impact on quality of life, the biggest things that drive these impacts seem to be ongoing concerns with incontinence and if they're experiencing any kind of kidney failure. So now that you guys have an understanding of what PUV is and how it's managed and what to expect as children grow and develop into adults, I can give you some background about the PUV clinic and the care philosophy and why we developed this clinic. We've seen in the previous slides the variety of outcomes that these kids can experience and how some of them range from fairly mild to severe and all the way to kidney transplant. The reason why we decided to create this clinic is because we believe that there is a way to improve these outcomes, and that's by being proactive versus reactive. And what does that mean? This means that we don't wait for things to happen before we offer interventions. So most of you are already pretty aware, because you've been coming to Valve's clinic, is that we have certain triggers that we use to let us know when certain interventions would be required. And that includes the initial surgery that we offer. And so surgery historically was attempting a valve ablation for every child with PUV. And we know that after that, some of them went on to experience infections, worsening hydronephrosis, rising creatinine, and they ended up needing a diversion to happen after the fact, like a ureterostomy or a vesicostomy. And now that we've individualized the management, some of these children are offered these surgeries as a first-line attempt at decompressing the kidneys to preserve the kidney function. And so surgeries are individualized now based on how the bladder responds to drainage, how the kidneys and ureters respond to having an empty bladder, how the creatinine values respond to bladder decompression. And based on all of this information, that's how we determine which surgery would be most appropriate for which child. So considering surgeries, there are some that will be offered or be necessary later on as the child is progressing. So for example, if a child is managed with a valve ablation as a baby, if there are issues after that, like infections or poor emptying, worsening hydronephrosis, worsening creatinine, a diversion like a ureterostomy or a vesicostomy shown in the previous slide might be offered at that point. The example here in the picture, if you look closely in the child's belly button, there's a very small stoma that's hidden there, and this is called a Mitrofanoff. We offer a Mitrofanoff because it facilitates catheterizations for kids who don't tolerate catheters through their urethra or their penis because it's uncomfortable and they can feel it. This is a very good option to help with catheters for that population of kids, and it also helps with independence, as we know that kids who catheterize with this method are typically able to do it on their own at younger ages. Botox is another thing that we offer, and there's a few reasons why we might suggest Botox. One of them is because when we inject it into the bladder, it relaxes the bladder to decrease the pressures. In kids who have accidents because of a small capacity bladder, it helps to relax the bladder so that you can hold more urine. And it also decreases the need for oral medications, which can sometimes be associated with some bothersome side effects. Sometimes in younger kids, we offer Botox to the bladder neck or sphincter. And the reason we do that is because it decreases the resistance of the bladder, so the bladder is able to empty more effectively without having to work so hard. In very rare circumstances, a suprapubic tube might be indicated, and that's a catheter that actually goes through the abdominal wall into the bladder. And that's something that can be clamped and unclamped and used for bladder cycling. And it can be used as a safety measure to help the child keep the bladder empty while we're looking for time to be able to proceed with a Mitrofanoff procedure, for example. When it comes to medications, there are some medications that are quite common for kids with PUV. The first category is anticholinergics or beta-3 agonists. This includes oxybutynin, solifenacin, and mirabegron. And so what do these medications do? These medications help to relax the bladder, so similar to Botox in the previous slide. It decreases bladder inside of the pressure, which helps keep pressure off of the kidneys and to preserve kidney function. It helps to soften the bladder wall. And what that means is that sometimes, particularly in babies, the bladder had been having to work so hard to empty that the wall becomes thick. The pressure inside is high. And so by offering anticholinergics, we can relax the bladder a little bit, soften the bladder wall so those kidneys and ureters can drain with less resistance. Another reason that we use them is to help with pee accidents. Why we start them? So we start them if the child has been shown to have a high pressure bladder on a test called urodynamics. We use them if there's worsening hydronephrosis or hydroureter because the bladder is looking thick. We use them if the child is post-toilet training age and is continuing to have issues with urinary incontinence.
And then we also start these medications preemptively before we close any diversion. And what that means is that if your child is managed with a ureterostomy or a vesicostomy, this medication will be introduced a few weeks before we close those diversions to help to optimize the bladder function in anticipation for it having to do all the work in terms of eliminating urine from the body. What are the main issues with this medication or this family of medications, particularly with anticholinergics? It can make emptying, or it can make poor emptying worse, which means sometimes you can relax the bladder so much that now the bladder is not able to squeeze all the pee out each time. Anticholinergics also can sometimes impact or cause constipation, which then we know also has a negative impact on bladder function. And with beta-3 agonists such as mirabegron, we know that it can cause issues with blood pressure. Another medication that you guys might be familiar with are in the alpha blocker family. The most common alpha blockers that we use are tamsulosin and silodosin. And so what do these medications do? These medications help with bladder emptying. They relax the muscles around the bladder neck so the bladder is able to squeeze with less resistance. And it also works on the receptors to relax the entrance of the ureter into the bladder. So in terms of a bladder that's very thick and causing the ureters to be slow to empty, this medication will also work on the receptors around that site to relax, to hopefully allow the upper tracts or the kidneys and the ureters to drain with less resistance. And so why do we use these? So in babies, we may offer tamsulosin if every time you come for an ultrasound, the bladder always looks very full. As the child gets older and is able to do the flow studies, we use these if there's consistent issues with incomplete emptying. So if there's always a high post-void residual, an alpha blocker might be initiated at that point. We will also offer them if there's worsening hydronephrosis for the reason that I just mentioned. We will offer them if there is incontinence. And again, we offer them preemptively before we close any urinary diversion. Main issues and side effects with alpha blockers. We know that it's sometimes hard to give these. This is not a medication that's typically intended for small children. This is a medication that's usually used for men with large prostates and they're having trouble peeing. And so dosing in babies is often difficult or challenging. So we know that that is one challenge with this medication and something that we're working on with our pharmacy team. We know that tamsulosin can't go in G-tubes because it has a tendency to clog. So if you have a child with chronic kidney disease with a G-tube, we know that in that case, the silodosin medication would be a better fit. And then the main complications or side effects that happen with alpha blockers is that they can sometimes be associated with dizziness related to low blood pressure. We actually just did a study here where we looked at all of the kids who were taking Flomax or tamsulosin, and we noted that most of them, almost all of them, did not experience any significant side effects, and most of them tend to be very well tolerated.
Finally, some of the other medications that we may encounter with kids who have PUV managed in our clinic, we have antibiotic prophylaxis, and that is used to prevent infections. And this is a medication that can be given by mouth, or for kids who do catheters, we can infuse this directly into the bladder once a day to help to keep the urine sterile and prevent systemic urinary tract infections. We also use stool softeners such as Restorelax, and this is for the management and prevention of constipation because, as I've touched on a few times already, constipation can negatively impact bladder dynamics. And so sometimes we use these, especially during the toilet training age, to ensure that we don't have any constipation that's contributing to any bladder dysfunction. And then, of course, beyond the scope of this talk, there are also other medications that are indicated by nephrology, medications that help with blood pressure, and those related to chronic kidney disease for the kids who are also seen in that clinic. And I think an important thing to note is a lot of times people ask, how long will my child need to be on these medications? And the answer is that it's very variable. The children tell us how long they need each of these therapies for. And so if each time you come, things are looking very reassuring and it seems reasonable to stop a medication, we can always trial off and see how the child does. Most of these medications are usually used fairly long term, but indeed, we can certainly look at discontinuing medications when it's clinically appropriate to do that based on our child's response, with the understanding that at any point along the PUV journey with us, some of these things may need to be reinitiated at any point. So the next thing we'll touch on are tests that are commonly indicated for kids who are followed for PUV. And so the first test are ultrasounds, which all of you guys are already familiar with. Ultrasounds are used for regular monitoring. The benefits are that they don't incur any radiation, and we still get good information from them in terms of degree of hydronephrosis, what the parenchyma looks like, and how the bladder is looking and ability to empty. The next test is the VCUG, or voiding cystourethrogram. This test is the gold standard test for the diagnosis of kids with PUV. We also sometimes use this test to check for residual valves if there's any concerning findings on ultrasound during follow-up. This test also tells us about the reflux status. The downside to this test is that it requires catheterization and it does incur some radiation, and kids find it uncomfortable, particularly as they get older. Another test that's similar to the VCUG but gives us a little bit more information is video urodynamics. We order this test if we have concerns about bladder function. More and more, we're ordering this at regular intervals, so we have a good understanding of bladder dynamics as PUV kids pass through those milestones I mentioned before. And certainly this test is indicated in order to work up a child if they're heading towards transplant. This test will tell us about bladder dynamics, such as pressures when the bladder is filling or when the bladder is emptying. It gives us an idea of the true bladder capacity, the ability to empty completely, and it also provides that information about reflux. The drawback of this test is that it does require a urethral catheter, but it also requires a small catheter or tube into the rectum or bum, and that allows us to measure abdominal pressure while the child is having their bladder dynamics assessed, and it does incur some radiation as well. Finally, the last test that may come up is something called the nuclear scan, and this is a test that could be ordered to give us an accurate estimation of kidney function. This also would allow us to check for scarring after urinary tract infections, for example. This test is not one that we commonly order, but sometimes there is an indication. The drawback of this test is that it requires an IV. It also requires a catheter, depending on the type of nuclear scan that we order. And again, there is radiation that's associated with this test. Okay, next up we have catheters. Catheters is a big topic that comes up a lot of the time in PUV clinic and outside of PUV clinic in terms of the rationale for doing them, how to help children cope with them, and how long that they're going to have to last. So why do we do catheters? Well, most issues with PUV are directly related to bladder function. And so you have a bladder that's not working effectively, that's generating high pressures. Eventually, over time, that pressure is transferred to the kidneys. And if you think about the main goal of management of PUV, it's to preserve kidney function. And from a urology standpoint, the way that we do this in this population of kids that we follow with PUV is to optimize the bladder function as best as we can. And so when I say most issues with PUV are directly related to bladder function, that means rising creatinine, worsening or persistent hydronephrosis on serial ultrasounds, evidence of poor emptying, either with the ultrasound or with flow studies, development of infections or incontinence despite active attempts at toilet training. All of these are likely a direct result of issues with bladder function. And so when we think about types of catheters, we have intermittent, which means that they are in and out at regular intervals during the day, and that's how we can ensure the bladder is emptying completely. Overnight drainage, so that's a different type of catheter that we use at night when kids sleep. And we say overnight, but we mean for at least 12 hours. And that means that there's no pressure on the kidneys for half the day. Plus, we know that PUV kids make a lot of urine overnight. A lot of them are producing all this urine, the bladders become distended, and if they don't wake up to pee or they don't leak, all of that pressure is on the kidneys for the whole time that the kid is sleeping. And so this means that there are no overfull bladders. And another reason why we may try catheters would be that if we see a creatinine that's going up or hydronephrosis is getting worse, we can do a catheter test. And that means that we leave the catheter in for 1 to 2 weeks. And we repeat testing at that time to see if the creatinine and the hydronephrosis looks better with drainage. If we find that, it is evidence that by improving the bladder dynamics and improving the bladder function with intermittent catheters and overnight drainage, it will make the ultrasound and the creatinine look a little bit better.
So in terms of teamwork, as a lot of you would have already experienced, when we have a PUV clinic, you'll receive a survey the same day or the next day asking you about how your experience was in the PUV clinic. And you'll also get a survey after the support group sessions. And that's super important for you guys to answer because we use that information to help us understand the issues that are important to you. And so to date, the information that we're getting from these surveys is that when we think about the most important topics to you as parents in taking care of a child or parenting a child with PUV, the most important topics that you want to know about are quality of life, kidney function, the disease course, toilet training tips and tricks, what happens with bladder function, and of course, when and why your child would require catheters. And again, this information is very important to us because we take this information, we bring it back to the team, and this helps us tailor education sessions like this and to implement other strategies and tools in clinic to help make sure that you guys are understanding our rationale for offering interventions that we are. And so when we asked you guys, what are the things that parents are most worried about? And so the common themes that come up here are future interventions. Will my child need a transplant? Will my child need dialysis? Or will they need extra surgeries? There's also another common theme about quality of life. So how does having this diagnosis of PUV impact my child's quality of life? Again, the catheters theme came up here, disease process or disease progressions, and medications, which ones, why do we need them, and for how long?
And so this question has actually been super helpful to us. This is a question where we ask you guys what you want us to know about what it's like to have a son with PUV and what's important to you and things that we can improve on. And so you've told us that the experience is full of fear and anxiety, and we completely appreciate that. You tell us that you want more information, especially when you come to clinic and we're relaying results and we're talking about how your child is doing. You've told us that you have major concerns about the course of the disease, that there's challenges in the day-to-day care. You want to know about urinary tract infections, how to recognize them, and what would be the impact if your child develops them. There's a concern about getting different information from different people. And on that note, of course, being in a teaching hospital, you may have a different person come to see you when you come to PUV clinic, and that may mean a resident or a fellow or a medical student. However, it is always well within your rights to ask to speak to Dr. Dos Santos or I to help to explain the change of plan or to explain rationale for certain interventions if that's something that you're not comfortable with. You've told us that you want prioritization of mental health and more resources for this, and this is something we are actively working on. And then something that we did not consider and that we maybe don't consider as the healthcare providers is that there's a significant financial cost associated with care that's a burden to families. And whether that means catheters, whether that means your child has a urinary diversion like ureterostomy that requires extra diapering, it is important that you bring this to the front of our minds. So when we're meeting with other families, this is something that we can bring up front when we're talking about different management options. And these concerns are important to bring up because this gives us objective information that we can bring to leaders and decision makers when it comes to advocating for more resources for this population of kids. This is one example that we have come up with in terms of needing more information. We understand that sometimes the information that you get at clinic visits are overwhelming. Those are long clinic days. Sometimes children have to go through a lot of tests. By the time we're seeing you in clinic, naps have been missed, kids are tired, they're hungry, and it might be hard to absorb all that information. Additionally, it might be hard to remember where your child was at the last ultrasound and where your child is now. And in an attempt to avoid us coming and saying that ultrasound looks good, or this is the measurement, or everything looks stable, this is a tool that we came up with that allows us to objectively communicate the important findings to you. So we can let you know what the ultrasound looks like, all of the specific numbers that we look at, explain what all of these parameters mean, give you a visual diagram of where your child is sitting in terms of chronic kidney disease, and if they're toilet trained, give you objective parameters about how they're doing in terms of their flow studies. And this is developed as a direct result of feedback that you guys have given us. And this is still a relatively new tool that we've just started implementing. And so if you come to a visit and this tool is not provided, then you need to feel free to ask us for it. And we are more than happy to provide this at every clinic visit. It allows you to speak the same language as us. It allows you to be able to objectively track the progress of your child in the same parameters and framework that we do. Another thing that has improved since we've been doing the support group and the clinic feedback is that we've developed educational materials specific to PUV, specific to how we manage these children at Sick Kids, that are available on the Sick Kids website about kidshealth.ca. And this comes from a feedback that's saying someone thinks that a pamphlet should come home with information for their family members about the importance of all the interventions that we suggest. It's easier to explain to families the importance of these things if you have it official coming from the healthcare team. The quote is, if it comes from the doctors at Sick Kids, they would listen better. And so based on this, we as a group came up with these two educational documents located on the Sick Kids website. One of them explains in detail about what is PUV. The other one explains in detail essentially the contents of this talk that I'm giving you tonight, that goes through all of the different treatment options with medication and surgeries, and these are free to anybody who would want to access them. Another common theme that's come up in these surveys is how PUV impacts the quality of life of kids with this condition. Some of you may have noticed that when you come to clinic, we do request that you fill out a questionnaire in order for us to understand this issue better. This has not been a very well studied topic in the PUV literature. And the only way that we're going to understand this impact is by getting that information from you and from understanding what you guys are telling us. And so the tool that we use measures total physical and psychosocial impacts on quality of life. Each of those sections has a possible score of 100. And if you get a higher score, that means the quality of life is better or less impacted. And so we've had 112 families fill out this questionnaire so far. The total overall score is 89 out of 100. The total physical score, and so how the physical well-being is impacted by PUV, is 88. However, the psychosocial impact of PUV ends up being around 76. So when we looked at all these scores and we compared them according to other factors, such as age of the child who's completing the questionnaire, the type of surgery that your child initially had, we didn't really notice any major differences between any of those variables. When we looked at kids, though, who need to do catheters and compared them to kids who don't, so these are all PUV patients, some do catheters, some do not, we did notice that the scores of kids who do catheters were significantly lower in the emotional well-being domain. And so we can see that in kids who have to do this intervention, that it seems to have a somewhat negative impact on their emotional quality of life. When we compare scores of PUV kids to otherwise healthy kids without a chronic health condition, we found that PUV kids score similarly. Within our PUV population, we did notice that overall, there seems to be a difference between physical impact and psychosocial impact, meaning that there's very little impact on the physical quality of life in children with valves, and that most of the impact seems to happen in that psychosocial domain. And why that's important is because having this objective data, again, helps us to have the information that we need to go to leaders and decision makers to advocate for resource in PUV clinic. And so many of you have mentioned the need for mental health support. And it's information like this that you guys are willingly providing that we so much appreciate, that give us the tools that we need to help to make this program much stronger and to be much more holistic than what we're currently possible at having. So to wrap up, we all know that PUV is a rare condition that some kids are born with. PUV occurs on a spectrum, and every single child with this condition is different. We, as the urology team at Sick Kids, are committed to providing care for all aspects of your child's condition from clinical, social, and mental health perspectives. And we need to continue to have you guys, our families, as partners in this journey in order to improve overall care for these kids. Thank you guys so much for your attention and attending this talk this evening. This will be posted on the Sick Kids Urology YouTube channel if you want to go back and watch it again for reference. And at this point, I'm happy to take any questions that you guys may have. Thank you.